Snigdha Bharadwaj, Assistant Professor, ITS College of Pharmacy. So, we will be continuing our session with pharmacokinetic models. So, let us get started. So, in earlier session we have discussed about pharmacokinetic models through which we can identify different pharmacokinetic parameters. So, in which we have discussed model dependent approach as well as model independent approaches. So, in model dependent approach we have compartment models, physiological models and diffusion models. So, basically first we have started compartment models. So, now in compartment model, depending upon whether the compartment are arranged parallel or in series, compartment models are divided into two categories. So, as you know that these are fictitious things or fictitious models which we are considering for identifying pharmacokinetic parameter arithmetically. So, here in two different models we identify that a compartment is set in the parallel or in a series, right. So, it is divided based on the alignment of compartment, it is either divided into two parts, Mamillary model, Catenary model. So, Mamillary model, first we will identify Mamillary models. So, it consists of one or more peripheral compartment connected to the central compartment. So, basically the different peripheral compartments are connected to the central compartment. The central compartment comprises of plasma and highly perfused tissues such as lungs, liver, kidney, etc. For example, central compartment we consider blood compartment or plasma compartment, highly perfused tissues, and it is further connected into the peripheral compartment, and we assumes that drug is evenly distributed among all these compartments. The drug is directly absorbed into this compartment, yani ki blood. Elimination too occurs from this compartment, since the chief organs involved in the drug elimination are liver and kidneys. The highly perfused tissue and therefore presumed to be rapidly accessible to drug in the systemic circulation. So, means we are saying this thing that the drug is directly absorbed into this compartment from the blood, and elimination also occurs from this compartment, since the chief organs involved in drug eliminations are liver and kidneys. That means, the entry and exit we are considering is rapid processes if we talk about highly perfused compartments. Okay. So, blood is your central compartment, whereas kidney and liver is your peripheral compartments, though it is peripheral, but they have high blood flow nature, and so the absorption and elimination will be rapid in that case. The peripheral compartments or tissue compartments denoted by number 2, 3 in the next figure are those with low vascularity and poor perfusion. So, moving on to a next slide, we see that this figure is the central compartment is your Q1 and Q2 and Q3 is your different other compartments having low vascularity, and you see that the drug is going K is your absorption rate, right, constant. So, drug 3-1 means the one compartment moving to 3 and then coming to 1. So, K31 represents that drug is exiting from the central compartment towards the peripheral one and then entered to the central compartment. So, through these you see in Mamillary model the compartments are aligned like this, the attaching to the central compartment. So, here are different compartments you see in the Mamillary model. The alignment is kind of same, but we consider different kind of compartments. So, in this figure you see one compartment open model, intravenous administration. Intravenous administration we will cover in next upcoming sessions. So, you see only one compartment is there and drug is moving out to the further eliminated out. So, in model 2, one compartment open model, extravascular, oral, rectal and etc. administration. When we give the drug through IV administration, we consider body as a single compartment, open compartment, and we see that the drug is uniformly distributed all over the body. When we see, because one compartment is a blood compartment we are considering and it is circulating all throughout the body, and one model 2 is your for extravascular we can say regions or tissues like oral, rectal administration. So, in on that case we consider that model number 2 one compartment open model, right. In model 3 two compartment open model for intravenous administration. Again we when we the drug is given intravenously. So, apart from that one compartment, we generally we also consider the drug as two compartment from moving from highly vascular area to the different peripheral areas. So, model 4 is two compartment open model extravascular administration, model 5 three compartment for IV and extravascular administration. So, based on the type of drug and the type of therapy you are studying, type of parameters you are studying. So, you can select any one of those as per your requirement. Next, the catenary model. So, in this model the compartments are joined to one another in a series like compartments of train. So, you see in the picture itself the compartments are aligned like a train compartments. This is however not observable physiologically or anatomically because the various organs are directly linked to the blood compartment, hence this is rarely used. If you see that the first drug is entering to the one compartment and then going to second compartment and from second it is going to third. No, it is not. It is having low correlation with the biological experiment, as the body is totally connected with the central compartment which is your blood, and then different organ you can consider different compartments. But here if you see the picture, you see that the drug is entering to first compartment and going to second compartment, and after that compartment it is going to third and more and more. So, it is not at all possible. The blood is a central compartment which is connecting to every compartment, but second is not third is not connecting to first compartment. So, this due to this disadvantage, so it cannot be easily correlate with the biological experiment and hence rarely used. So, once again you see the picture, the mamillary model, different models, model 1, model 2, model 3. That means, in one model you see one compartment, in second model you see two compartments, in three models you see three compartments. So, compartment arranged in parallel to central compartment. All of the compartments are connected directly to the central compartment, but in that catenary model one compartment is not connected to the directly to the other compartment except second compartment. So, it is rarely used as it gives no exact analysis based on the models. Physiological models. After compartment models, we also covered physiological models under model dependent approaches. So, they are drawn on the basis of known anatomical and physiological data. Basically, these models, as name indicates, physiological. So, they are basically designed based on the physiological parameters of profile of the body. So, it presents more realistic picture of drug deposition in various organs and tissues, as these are designed based on the physiological and anatomical data. So, the data analysis will be quite relevant and quite precise, we can say. tissue with similar perfusion properties are grouped into single compartment. Based on that vascularity, as I have discussed in my earlier session, that body is divided into 4 compartments based on highly perfused areas, poorly perfused area, below that poorly perfused, and fat tissues, right. So, based on the highly perfused, the organ coming in the highly perfused category will be considered as single compartment, as the blood flow and the binding affinity towards drug will be quite similar and uniform. So, we can consider all these organs which have similar type of blood flow and binding affinity as one compartment. So, tissue. So, as this model indicates the physiology of the organ, or we can say the body part. So, on based on these viscolarity and the physiology of that particular organ, we can design a particular model, and that will be considered as physiological model. So, based on anatomy of the organ, we say that due to the nature of this organ, so we can consider that as one compartment. So, tissue with similar perfusion properties are grouped into a single compartment. For example, lungs, liver, brain, kidney are grouped as rapidly equilibrating tissues, as they are highly perfused. So, we can say that all these organs can be considered as, or can be considered or taken as one compartment, because all the binding and distribution pattern of drug in those organs are similar. While muscles and adipose or fat tissue, we can say a slowly equilibrating tissue. So, these are sum up as a different compartment which has different blood flow profile and binding affinity towards drug. So, all based on these physiological variation, we can group different organ as similar compartment pattern. So, you see here the venous blood and arterial blood. So, different organ is connected to that particular blood compartment: lung, heart, kidney, liver, stomach, tissue, organ of toxicity, tumors. So, there are different compartments. If you see that lung, heart, kidney, liver, so these are highly perfused, whereas GIT is also highly perfused. Tissues, organ, tumors. So, based on their connections, so we can say that lung, so venous blood and arterial blood. So, our venous blood is going to the through the lung to that particular exchanges happening here. So, this is just to show how the compartments can be considered highly perfused and all, right. So, model independent approach. So, first we have discussed model dependent, under which we have discussed that compartment physiological models and after that model independent approach. Model independent approach are further divided into 2 categories: distributed parameter models and non-compartmental analysis. So, distributed parameter model, first it is an analogous to physiological model, but has been designed to take into account variation in blood flow to an organ, variation in drug diffusion in an organ. So, basically it is similar to that particular what we say particular model. This distributed parameter model comes under model dependent approach, and this non-compartmental analysis will come model independent approach. So, the third one is distributed parameter model under model dependent approach. It is written by mistake here to model under model independent approaches. So, distributed parameter model is quite similar to physiological model, but has been designed to take into account. So, 2 considerations is generally taken while designing this type of distributed parameter model, because we are observing distribution pattern of a drug among different body compartments. So, here two points needs to be taken into consideration. First is variation in blood flow to an organ and variation in drug diffusion in an organ. So, variation in blood flow to an organ, like different organs has different blood flow pattern as well as different binding affinity. So, they take into consideration, but whereas in physiological model we take all the organs having similar type of blood flow, vascularity and binding affinity into and consider as one compartment, or we see that all the drug distribution and drug is equilibrated uniformly among all these type of compartments. So, in this distributed parameter model we observe any variation in blood flow to a particular organ. That means, every organ has its different blood perfusion, right. Variation in drug diffusion in an organ, how the drug is diffusing to that particular organ, the pattern of diffusion of drug into particular organ is also considered while designing this type of model. The distributed parameter model differ from physiological model in that mathematical equation are more complex and collection of drug concentration data is more difficult, because we are further fragmented our data into sub points. So, sometimes it is very difficult to analyze the exact data we are calculating because of complexity of the equations we are using in distributed parameter model. So, if we talk about generally that we are considering compartments, so the basic calculation will be quite easier, whereas if we see the physiology of the organ along with that particular distribution and diffusion pattern of the drug, the calculation will be more complex in that case. So, in non-compartmental analysis, it is also known as model independent approach, because it does not require the assumption of specific compartment models. When we discuss about model dependent approach, we always talk body as a compartment, or we always consider body parts are different compartments and considered their physiological or anatomical biological things into consideration to analyze the drug diffusion or drug distribution patterns. But here in non-compartmental analysis, these approaches does not require any compartmental assumption. This method is based on the assumption that the drug or metabolite follow linear kinetics. So, these are non-compartmental approach, but they usually take a drug that it is following the linear kinetics. So, the technique can be applied to any compartment model. So, that means drug is entering to the body and going outside without considering it as compartment, and it is behaving like and it is following linear kinetics. Based on statistical moments theory, so it involves collection of experimental data following a single dose of drug. So, basically when we talk that it is not considering any compartment, but it involves collection of experimental data following a single dose of drug. For single dose, we collect all the experimental data, and if one consider the time course of drug concentration in plasma as a statistical distribution curve, then MRT, mean resident time. How we calculate without considering the body as a compartment. So, they are just giving the equation through which we can calculate the experimental data and come to the conclusion, right. So, how we calculate the time course of drug concentration in plasma, how much the drug resident time in the blood, how we calculate using this equation MRT, mean resident time, AUMC and divided by AUC, where MRT is equal to mean resident time, AUMC stands for area under the first moment curve, and AUC stands for area under the 0 moment curve. That means, the time when the drug is administered and the time first it shows action for onset of action is your AUMC, right. MRT is defined as the average amount of time spent by the drug in the body before being eliminated. Mean resident time, total time the drug is residing within the body is known as mean resident time. So, AUMC and AUC can be calculated from the use of trapezoidal rule. So, trapezoidal rule will be in next slides. Like applications of pharmacokinetic models, how these models are helpful. So, characterizing the behavior of drug in patients, of course, we can see same drug can be act differently in different patients. So, analyzing these variations can be helpful if we use these type of pharmacokinetic models. Predicting the concentration of drug in various body fluids with any dose regimen, predicting the multiple dose concentration curves from single dose experiments, calculating the optimum dosage regimen from individual patient, yes, evaluating the risk of toxicity with certain dosage regimen, correlating plasma drug concentration with pharmacological response, evaluating the bioequivalence, bioinequivalence between different formulation of the same drug, estimating the possibility of drug or metabolites accumulation in the body, determining the influence of altered physiological disease state on drug ADME. That means, if any disease condition is there, whether it is impacting drug absorption, metabolism, distribution, excretion or not. Generally, it is affecting, right. For example, in diabetic patients, in patient with hyperlipidemia. So, many processes are hampered and the drug performance is overall affected. Explaining drug interactions. So, all these applications are basically these pharmacokinetic models are important to understand all these parameters. So, once again I would like to explain the highlights of my presentation. First, we have discussed mamillary two types compartment models, in which we have discussed mamillary and catenary models, in which the mamillary model, the central compartment is attached with the peripheral compartments, whereas in catenary models the compartments are aligned in a series like compartments of train. That means, the last compartment will not any connection with the first compartment. So, this is why it is rarely used, as the blood is considered as a central compartment, and in this it is not happening. So, this is the basic difference, and after that compartment model we have studied physiological models. In this, the mathematical designs are dependent on considering like physiology and anatomy of the organ, and based on the you can say vascularity of blood flow and binding affinity, we generally consider those particular organs as one compartment, those, or we see that drug is uniformly distributed based on their perfusion, blood perfusion through that particular organ. Whereas, the third one is distributed parameter model. It is mistakenly written here under model independent, whereas it is model dependent approach, the third approach, distributed parameter model, in which we generally during designing of component, we generally consider variation in blood flow to an organ and variation in drug diffusion. So, using these parameters, using these considering these profiles, it may make the complex the procedure more complex, as the data identification will get complex, will get difficult to calculate. And after that, non-compartmental analysis, this is also known as model independent approach. In this, basically we consider that drugs follow linear kinetics, and we can identify using this equation MRT AUMC divided by AUC, whereas it can be calculated using trapezoidal rule. So, considering trapezoid, and we can calculate. So, I will tell you in my next coming sessions how to calculate this, how to use this. So, after this, I hope these are different pharmacokinetic applications of these models, how they are helpful to identifying pharmacokinetic parameters. These are references. I hope you like the presentation, and till then, take care. Stay